basically a complication. How do we manage it?
It was another routine day at work when I had taken up a 40-year-old patient for surgery. He was
Please
phakic with
jack
a
up
clear
the audio,
lens
please.
and had a rheumatogenius retinal detachment with
ये
posterior
बंद होगा तो सभी
PVR
बंद हो
and
जाएगा.
choroidal detachment. I should have realized in the very beginning itself that this case will be different when I couldn't localize my infusion cannula in the vitreous cavity. It was in the suprachoroidal space. Keeping my cool, I carefully internalized it with the help of a 25 gauge MVR blade, taking care of not to touch the lens. I thought that the worst is over, and so it seemed so for most of the surgery. A complete pars plana vitrectomy with base dissection was done. Epiretinal membrane at posterior pole fold was negatively stained with retiblue dye and peeled with the help of Eckhart's forceps. Inferior retinotomy was done to remove the subretinal tissue and release the inferior folds. PFCL was injected to stabilize the retina, and then a 360-degree green laser retinopexy was done. PFCL silicone oil exchange through infratemporal cannula was started. I saw the first oil bubble come into the vitreous cavity, and then patient started complaining of extreme pain. I started seeing a mound rise infratemporally. I started to see red, hemorrhage. I started to sweat. I tried to see the cannula but could not visualize the tip. Oh my God, I realized that the cannula has gone into the suprachoroidal space and I have injected oil there. I thought all is lost. I tried to change the port from infratemporal to supranasal but still could not visualize the cannula. My mind started working on what options I had. Should I close for now and fight another day? Should I call for a backup? Can some other VR surgeon get me out of this? Should I still trust in my skills and cannula? Then it hit me like a brainwave, something which I had seen in my recent layer times. This was the time to recall something from the past.
The problem is when the capsule moves from an elliptical orbit to a parabolic orbit. There's no mathematical formula for that. As we can calculate launch and landing, but without this conversion, the capsule stays in orbit. We can't bring it back home.
Maybe it's not new math at all.
It could be old math. Euler's method.
Euler's method.
Yes.
That's ancient.
But it works. It works numerically.
That's it.
I asked for my 20 gauge 6mm sutured infusion cannula. We had not used it for long. Where was it? The OT staff went into a frantic activity. Will they find it? And yes, they did. I breathed a sigh of relief. I quickly removed 2 of my 23 gauge cannulas and put in a 6mm 20 gauge cannula. It was difficult to insert the cannula as the eye was hypotenuse. Because of the hypotony, the eye started to bleed profusely. For a moment, I thought I had an expulsive hemorrhage. With the help of a 25 gauge MVR, I carefully internalized the cannula in the vitreous cavity. With the pressure building up from the infusion, the silicone oil from the suprachoroidal space egressed from the other 20 gauge port. Blood was cleared with the help of a cutter. I could see a well-attached retina supported by PFCL and let out my first sigh of relief after long. Vitreous lavage was done for 10 to 15 minutes to clear the blood from the vitreous cavity. The clot seen inferiorly was then removed with the help of suction from the cutter. Carefully, I then completed my PFCL silicone oil exchange and closed my port. A major catastrophe had been averted. Post-op 3 months, the retina is well attached and the lens is still clear.
Oh my God, that is wonderful. Thank you so much, Dr. Gupta. I don't think we can have any questions on this case. May I call the next speaker? He had a question? 1 sec.
Why 20 gauge cannula?
So basically, if we do 20 gauge, first thing I need a longer cannula so that it goes inside the vitreous cavity. And if I do a 20 gauge, that means the suprachoroidal space directly comes in communication with the outside atmosphere. So converting to 20 gauge means that I am also draining the suprachoroidal silicone oil. So until unless I drain suprachoroidal silicone oil, I am not going to settle the choroids which are there.
Okay, I think that's fine. The next speaker is Dr. Piyush Kohli, and